Go ahead, sir.
Hello, a very good evening to all of you. I, Dr. Nilesh Balkawade, Clinical Head, Oasis Fertility, Pune. Welcome to yet another FB Live session. And today I'm going to talk about is partner important? And we are going to talk about male subfertility. Friends, Valentine's Day is approaching and we have 14th of February coming up. We all know the mutual love and respect for each other is very, very important. So once it comes to fertility, I think so this aspect could not be negated, and uh, it's as important to investigate and to treat a man than uh, just to treat a female or just to treat a woman. I feel so the responsibility is of both when it comes to childbearing. So whenever it comes to infertility, almost 50% of the reasons of infertility are due to male subfertility. Direct causes of infertility, 30% are due to men, 30% are due to women, and remaining 30% usually both are responsible to a same extent, and the problems can be with both of them. And therefore, male subfertility or evaluation of the partner in infertility is very, very important. It's always said, I keep my problems, my struggles, my mistakes to myself because in reality, no one cares. That's the problem with males. Usually, they don't have a person whom they can go to and speak out. Uh, Women usually can speak out to their siblings or to their mothers, and they're very quite comfortable about speaking about the sensitive issues to their uh, even their colleagues. But in men, usually, what happens is that men usually don't speak out. They keep their problems to themselves, and therefore, the problem remains unanswered. Now, investigating a man is very important, but history taking before that is again very important. There is A to Z of infertility, which starts from A from analysis of semen and to the advanced treatments of Z or zeta potential. We have already seen the contribution of male infertility to the total causes of infertility. So almost 30% cases of infertility are directly due to cause in men, and out of that, even 20% are due to mixed cases of infertility. Uh, Out of the causes in men, usually there are unexplained causes in 34% of the men, 17% have varicocele. Then there are problems such as hypogonadism, undescended testes, urogenital infection, immune system factors, and so on. Now there is a rising trend of male infertility as we see in female infertility, and we know that the sperm counts have started declining over years. The counts which we used to get previously, that's not the case currently, and therefore there is substantial data to say that the male subfertility is on the rise, and this is because of increased rates of obesity, poor diet or dietary fats, exposure to environmental toxin, exposure to addictions, and so on. So, is andropause approaching? Friends, usually it was thought that andropause, there is no condition called as andropause, but we know that male fertility can also decline, and more so after 55 to 60 years of age, it definitely declines. But with the increasing cases of male subfertility and increasing hormonal imbalances, we can have this andropause earlier also. We all know the physiology. So there is a hypothalamo pituitary testicular axis where the hypothalamus controls the action of the pituitary, and the pituitary in turn controls the action over the testis through certain hormones. And these hormones then act on the testicular tissue, that is to cause FSH secretion and LH secretion on the Sertoli cells and Leydig cells, which later leads to spermatogenesis. And there is a negative feedback mechanism which inhibits the activity of anterior pituitary and the hypothalamus. If you see the causes, male subfertility can be due to pretesticular causes, testicular or post-testicular causes. When it comes to pretesticular causes, hypogonadotrophic hypogonadism, then Kalman syndrome, that is anosmia and hypothalamic problems, coital disorders, erectile dysfunction, ejaculatory dysfunction, pituitary disorders such as craniopharyngioma, pituitary tumors, traumatic brain injury can be a causes. Testicular causes can be due to varicocele, cryptorchidism, Then genetic problems such as 46XX and 47XXY, that is Jacob syndrome, Klinefelter's 47XXY, Y chromosome microdeletion, and so on. Systemic disorders, hematological disorders, chronic gastrointestinal disorders can also cause testicular problems. Then testicular injuries, gonadotoxins can also cause problems. Post-testicular problems such as obstruction to the uh, vasa deferentia, then Young syndrome, external compression by infection or trauma, acquired blockages such as iatrogenic injury, vasectomy can all damage the outflow tract for the sperms. When it comes to male subfertility, it can be managed with adequate and correct history taking and examination. That's the first and primary initial thing. And then we come to the investigation. In the investigation, semen analysis is the most important thing. But other than semen analysis, certain other tests such as hormonal assays, genetic testing, ultrasound, then Y chromosome microdeletion, all these can be done along with the normal semen analysis. Then there is definitely a role for medical management, surgical management, and of course, if the patient has severe problem, then artificial reproductive techniques. Physical examination, there should be a focus on urogenital examination. So markers of hormonal imbalance, genetic conditions should be assessed. The testicular volume size should be taken into consideration. The vas difference should be checked. The ejaculatory depth should be checked. The semen analysis should be the first investigation of choice. So if the sperms are absent, we call it as azoospermia. If the sperms are very less, then we call it as cryptozoospermia. If the sperms are less, but we can see directly without centrifugation, we call it as oligospermia, less than 15 million sperm count, and normal sperm count we can also have. Then interpreting semen analysis is also important. Before that, we should tell the patient how to give a semen sample. That is also important. So the abstinence period should be followed. So there should be minimum 3 days and maximum 7 days of abstinence. Did the person ask for spillage? So if there is some spillage, you have to tell that there was a spillage, because the sperms are there in the first few ml of the semen sample, and if that is spilled out, then there can be falsely low levels. pH of the semen is important. Low volume ejaculates, such as in infections. High volume ejaculates, again in infections, can be responsible. A highly viscous sample can cause problems with the analysis. Round cell counts, standardization of labs are again important aspects. Repeat semen analysis can have to be done. When to order hormones and when not to order hormones. So minimum two semen analysis reports with count less than 10 million, low volume testis, persistently low volume ejaculation, sexual dysfunction. This is the cases where we order hormones. And when not to order hormones, normal sperm counts, unexplained infertility, and only asthenoteratospermia. Severe oligoasthenozoospermia, if the patient is there, then if we do the hormones, if there is normal testosterone levels, normal LH levels, and normal FSH levels, we call it as idiopathic oligospermia or azoospermia. If the FSH levels are high, that indicates testicular failure. If the FSH levels are low and the testosterone and LH levels are low, then that indicates hypogonadotrophic hypogonadism. If the FSH levels are high, but there is normal testosterone and LH level, then we call it as an isolated germ cell failure. Then there can be certain entity called as retrograde ejaculation. For that, we have to measure the post-ejaculatory urine sample. So if the semen, instead of coming in front, it goes behind and goes into the urinary bladder, we call it as retrograde ejaculation. Ultrasound and Doppler is another investigation which can assess the testicular size, C for varicocele, C for any ejaculatory duct obstruction, and so on. Then in the treatment, the easily and correctable things are the varicocele. So if you see a varicocele and it is a grade 3 or grade 4 varicocele, varicocelectomy is going to help you to improve your success rates. If the sperm DNA fragmentation is high, that can be measured with sperm disc chromatin dispersion or SCSA or tunnel assays. And if that is more than 30%, you can have male subfertility. In cases of azoospermia, evaluation should start with FSH measurement. If FSH level is increased, that indicates testicular failure, so you should be doing genetic testing, karyotyping, then Y chromosome microdeletion should be done. Then you should go for surgical sperm retrieval, such as microsurgical TSA in such cases. If the FSH level is normal, then it might indicate that there is an obstruction to the semen flow, and therefore you have to do a specific analysis of that. If the FSH levels are decreased, then you indicate it to do a brain CT or MRI, and this can indicate a hypo or a problem with the pituitary and hypothalamus. Genetic testing, which can be undertaken, are karyotyping, Y chromosome microdeletion, and CFTR gene mutation, especially in cases of obstructive azoospermia. Treatment options depend whether we have to treat the specific cause and correct it. Intrauterine insemination for mild cases of male subfertility. Artificial reproductive cases techniques in cases of severe oligosteroideatospermia. Individuals with genetic abnormalities can have problems later, and therefore we can also offer pre-implantation genetic testing for some men. Adoption and donor sperms are used for those who are not a candidate for ART and therefore whose problems are high. And if you don't get a sperm retrieval on microsurgical test. So this is the flowchart of analysis of man. Treatment options include lifestyle modification. So you can go for a lifestyle modification correction of your diet, exercise, sleep, and addiction patterns. And you should continue this treatment for at least 3 months so that it can act and you can get better results after 3 months. Antioxidants are medications which can be given which reduce the oxidative stress, and also these medications are to be used for a period of 3 months before we jump onto any other treatment. If there is infection in the sperm, semen, and you get more of pus cells or round bodies, you should give antibiotics. Where there is a hormonal imbalance and the testosterone estradiol ratio is reversed, then the use of letrozole clomiphene citrate can be indicated. In the cases where there is a gonadotrophic hypogonadism, we can also use HMG and HCG in certain patients. Intrauterine insemination or inseminating the processed semen inside the uterus is where you have mild to moderate cases of male subfertility. IVF or ICSI, usually when the sperm count is good, artificial reproductive technique is which is followed is in vitro fertilization. But where the sperm count is low and motility is low, we can go for a ICSI, that is the intracytoplasmic sperm injection. When there is obstructive azoospermia, percutaneous epididymal sperm aspiration can also be done, but this has certain disadvantages. And nowadays, people prefer testicular sperm aspiration, that is a TISA. So it's a blind procedure. Immobilization of testis is necessary, and sperms are retrieved from the margin where you don't have any blood vessels. Microsurgical sperm extraction or MTSA is a technique where you can open up the testis under the microscope, see the seminiferous tubules which are dilated, and select those seminiferous tubules for analysis under microscope, and then go for the sperm retrieval. Sperm selection techniques can be used for patients who have problems with the sperm morphology or those who have a raised DNA fragmentation index. So IMSI, PIXI, microfluidics are such techniques which can be used. Then there is a technique called as electrophoresis where the zeta potential is used for sperm selection. We have microfluidics technique where we have a microfluidics chamber where we put in sperms in one chamber, and the fastest moving and the best sperm, which is less DNA fragmented, can be selected by the technique called as microfluidics. Then another technique called as magnetic cell sorting can be used for selecting sperms which are less damaged. So sperms are treated with annexin 5 molecules, and the sperms which are damaged can get attached to this, and then they can eventually get attached to the magnet which is provided, and the sperms which are less damaged are collected in the lower side of the container. This is how the match technique takes place. Then problems in men who have severe problems and have non-obstructive azoospermia, they might need a pre-implantation genetic testing so that we are sure about their success. Future is a long way to go, and people are also thinking about creating male gametes outside, but that's not which is currently being useful. But nevertheless, we have discussed about all cases of male subfertility. Please remember that speaking out is very important, and believing in yourself is also important. Believe in yourself, male subfertility can be treated in majority of the cases. Getting a proper consultation and getting a in-time consultation is important when it comes to male subfertility or assessing the partner as we discussed. So, friends, that's about male subfertility on the perspective of Valentine's Day. If you have any queries, please let me know. Thank you. One question coming up to you is, what is the initial investigation for male subfertility? So the first investigation, foremost investigation, is semen analysis. After that, if the semen analysis shows any problems, then you can undertake other analysis such as the hormone assay, ultrasound, genetic testing, and so on. What is the cause of subfertility? Yeah, there are many causes, but infections, then uh, pre-testicular causes, testicular causes, and post-testicular causes are the causes of male subfertility. I have already described it in the lecture. So if you have got any queries, please call us on the Oasis Fertility helpline, which is displayed on your screen, or you can come for a free consultation at any of our centers at Pune, that is Oasis Fertility Wakad and Oasis Fertility Karadi. That's all from now. I, Dr. Nilesh Balkawade, Clinical Head, sign off for now for yet another FB Live session next Monday. Thank you so much.